Hi. So my perspective is kind of unique. Remember, I mentioned before, I look at people, I'm looking for pelvic floor dysfunction, scoliosis, hypermobility. And I happen to see already by this patient that she has a scoliosis. And so I'm just going to show you really quickly what I see. So I'm going to get you to stand up. And why is scoliosis important? Because we can't change it. Scoliosis is a fixed position of the bones. So all we are looking for is how can we create motion within the muscles on either side to release the tension that's inside and then take the torsion out of what's going through the midline of the body. Important for us to remember that we're more than just what's happening on the outside. If there's a bit of a twist in our spine, it's going to affect all our organs and everything on the inside. Not that you need to know anything about those in particular, but that you need to be aware that they need to be treated as well and that they're part of the whole. So actually, I'm going to get you to face me just for a quick second. Good. And then just give a little hop because I saw you position your feet. Perfect. So I can see already by looking that she's more forward on her right side. Her left side is back. Her right hip, she has an anterior pelvic tilt. I can see that she has what we call a type 4 curve. And that means that her back looks very flat. And then because her back looks flat, there's actually a rotation through the lumbar spine. And so that's going to affect low back pain and tuck the pelvis underneath. So I'm going to have you take a seat. And is there anything in particular that's bothering you today? Your right hip, which makes total sense by what we're seeing because the right hip is forward. And does it bother you in every range of motion? Okay. So I'm going to take the tension off that, but I want you to know that the pain that she's having, she said she has pain that runs along the outside of her leg. It's actually being caused by the rotation. And so when we have a bit of a scoliosis, the spine, instead of hanging straight, that bit of a deviation in it changes how the muscles drape down. So I want you to think about it like the bones are the hangers, the muscles are the clothes, and then in between the clothes runs all the vascularity, nerves, veins, arteries, and lymphatics. So if we have a bit of a twist in the bowl, which we can't walk like this. So what ends up happening is the twist then becomes a rotation so that our pelvis can be square because our body wants to be square. But the twist is still going through the midline of the pelvis, which is causing how the muscles are draping down, which is impinging or not allowing fluid or nerves to do their job running through. So if I just treated it like it was her hip pain and I went right to the source of pain, I'd actually be missing what's causing it. And so although I may be able to touch her pain and find it, I'm not actually going to be able to affect it if all I'm doing is stopping the pain where it's happening. I instead have to look at what is the line of pull that's causing the pain. So I'm going to get you to lie down on your back. And you've seen it done before. That quick assessment of where internal and external rotation is on the legs. So lifting up her legs, first of all, I check to make sure it's a good lever. Because if she's hypermobile, which almost all people that have a scoliosis typically tend to be hypermobile, if I pick up this lever, it's not going to be good. But she actually has a good lever. So I'm going to pick up and check. Can her hip move into internal rotation, external rotation? So I'm going to check the motion. So it actually, her hip likes to go in. It does not like to go out. I'm going to check the other side. So again, does not like to come in, easily moves out. So that tells me, remember I said at the beginning that her pelvic floor was tucked under. If we think of our pelvic floor, or her pelvis, if we think of our pelvic floor in 4 parts, right? 2 at the front and 2 at the back. If my pelvis is tucked under, I'm going to be short and tight at the front, long and tight at the back. It's tight in both directions. I can't change long and tight. The only thing I can do with long and tight is to ask her to contract it to make it short and tight. But I can release short and tight. So I'm going to release adductors and the inside of the outside edge of her pelvic floor, which I can reach with my hand. And I'm going to show all of you guys that in just a second. And I'm going to release it bilaterally and then see if that changes how the legs move. So is it okay if I put my hand on the inside of your thigh? Perfect. Bend your knee. So I'm going to hold my hand on the top of the hip, hold behind the femur. And again, I'm just going to recheck that internal, external rotation of the hip, just to make sure. And I can feel when I do that her adductors are way too tight. So the adductors are pulling down at the front. So I'm going to place my hand on the inside of her thigh where the adductors attach onto the edge of the pubic bone. So I come in. Be okay with that? Make sure I'm not anywhere that I shouldn't be. I'm going to get her to push her leg out to the side. Good. Awesome. And then relax. And so I know that feels a little bit tender where my hand is. As soon as it just feels like pressure, I want you to push your leg back out to the side. So all I'm doing is putting direct contact on, and that is allowing her the opportunity to release the muscle, relax. I'm going to hold that pin, lengthen the leg out to the side, straighten out your leg. She's going to add the contraction there that allows that muscle the opportunity to release. I do just a little bit of oscillation, get the hip moving. Going to do the same thing on the other side. Bend this knee, reach behind. I hold the hip, reach to the inside of the thigh, push down and in. Good. And relax. Perfect. Do it again. And relax. So what I feel when I feel the muscle relax is just loss of tension. Perfect. Good. And then I recheck. A little bit of an oscillation. Good. Come up. Now we have internal, external rotation on both sides. Roll to your side, take a minute. Good, and then sit back up. We're actually going to sit all the way up. Yeah, I'm running out of time. All right, so we're going to get you to stand up. Perfect. And if you want to face me, do a little hop so that you can't position your legs. There you go. Perfect. Awesome. And how does the pain feel? Awesome. Yeah, so in that short 8-minute treatment, I'm not looking to release all of the tension, but I am telling you that if all I did was try to affect where the pain is, I wouldn't be changing the result of it. And then I would send her home, ask her to stretch out the front of her pelvic floor. I'd give her some exercises to do. I think more than likely it's just tight because of the shape again of the spine. And then, give her some breathing techniques as well. And that's it. You're so welcome. Thank you, Kara.
All right, I'm going to be your host for the next 8 minutes, apparently. Your name is? Kara. Nice to meet you. Nice to meet you, Miss Kara. Do you know how lumberjacks shake hands? They do this. And you grab my thumb. Like that. Okay? All right. So we're going to do a quick assessment of your hip, and I'm going to challenge you all in practice to make your assessments therapeutic. All right? So what I would love to see is, can you do a squat for me? To the best of your ability, hang on to the side if you need it. I think you'll be fine though. Okay, very nice, very nice. What if we asked you to squat deeper than that and I held your hands while you did it? Nice, and then all the way back up. Did you know, not that you're over 55, but after the age of 55, your ability to squat can be correlated with your mortality? So yes, so what I usually give for most people, I would have you do squat assessments for everybody. And your range was actually pretty good, but I think we can build your strength up a little bit. The other thing you could do is range of motion checks at the very start. And I had this the earlier presentation. How many of you are doing range of motion assessment with every patient? Okay, I need you all to lie to me. Put your hands up, liars. Okay, we're all doing it. Let me ask you this. She's got tight glutes, iliotibial band. You can say hip flexors or something like that. If I have you bend forward and touch your toes, so just bend forward and touch your toes, what did she actually do in this position right here? Yes, this is a baseline assessment, but what else happened? This was a way for her to lengthen out that tissue with her body weight to do it. Go ahead and come on back up. Is that more force than I can probably generate myself during the treatment? Yeah, it probably is, because the muscle's in a lengthened position. Gravity is your friend in moving down. So already your treatments are going to be more effective if you just do range of motion assessment. Okay. All right. We'll get you on your back and go through a couple of key things here. If anything we do is too much, let me know right away and we'll go through. All right. What is a good assessment? Which hip do we actually want to work on, right? Okay, I'll do cross body so people can see. I'd normally be on the same side, but because the table is so wide, I'm going to have you scooch this way. And that is the technical term, scooch. Okay, scooch over. Okay, everybody tell me what the name of this test is right here. So again, if anything's too much, let me know right away, Ms. Carol. Okay, what is this? What am I doing? No idea. Okay. This would actually be the start of a scour test right here. Really, what am I doing physiologically? I'm trying to introduce motion in her hip that's hopefully not painful. Now, if that was painful, was it painful at all? Yeah, so if it was painful, that would tell me I probably have to look at some kind of very mild soft tissue injury to work with. And I want to make sure to rule out deeper things inside the joint, so we're going to turn this into a scour test, okay? So you'd start off nice and light, then I'm going to bring a little bit of pressure. For those of you who are closer, we'll actually see the foam goes down a little bit. I'm going to push in a little bit like that. How does that feel? Yeah, no problem. And you can feel me load into the joint, and we'll move you around again. And how are you doing right there? It's good, apprehensive good, but it's still good. Like there was no pain, right? So for a lot of people, even that motion right there, they think it's going to be painful. It's not painful. We're building up your nervous system tolerance to the load that we're putting in there. Now this next one, it's going to be a little bit awkward because I'm cross body, but we'll try. So you're really going to bring your weight. I'm going to sink in like this and then move you around. And how are you doing there? That's not so good, right? What does it feel like? Okay, well, that's a little bit different. You're not following the script, okay? All right. What you're supposed to tell me is, oh yeah, I feel pain deep inside my hip. And then I would say, you know what, maybe we should have an x-ray done just to make sure we don't have concomitant osteoarthritis or something else like that going on at the same time. Not a big deal. Even if you did have it, I still care more about your functional capacity. But if you push down like this and she feels pain in her low back, what are you challenging more? Does anybody remember? Or you might even know this test as a thigh thrust test where we actually do this. Yeah, it's actually going to be more SI joint that's involved with it right there. How are you doing with that push? Yeah, okay. All right, but I want to keep this hip specific because that's what we're supposed to do for the crowd right here. And just for the purposes of making this easier, I'm going to use this hip so everybody can see it. So I am a big fan of instrument-assisted techniques. They have changed the way I have practiced in the last 15 years, just saving my hands. And I did this for the last one. How many of you have aching in the ips? My kids call these are your ips, my little French-Canadian kids, okay? Your interphalangeal joints. How many of you guys get aching of the interphalangeal joints? Be honest, okay? We have good stats on this from the physio world. Scott's putting his hand up, absolutely. Most of us are doing something like this, right? Where we'll push in with our thumb and we'll find I'll find your ASIS, just roll medial, sink into the upper fibers of psoas and dig in there. On a cadaver dissection, have you seen how big psoas is? Okay, how thick is it? It's like this. You're pushing into a massive, strong muscle right there through these itsy bitsy little joints that probably aren't designed to carry that much weight. So what I've been doing for the last, 15 years-ish is it's going to be way more intense because way more pressure than I can generate with my hands. So let me know right away. Okay. Is I'm going to use my iron thumb right there. That is literally the shape of my thumb, except now all the force can go through the palm of my hand. And just to make this easy for everyone, we'll put this leg straight. There's a couple of ways you could do it. If I'm dealing with one of our football players, Dave always comes to mind when I think of this. You're not Dave. 6'7", 367 pounds. So what does that mean? That means his thighs are the same size as my waist, basically. So I would let him do is just let the body weight, his leg weight actually just bring himself back and forth. But for your size to my size, good control against the hip. You can go ahead and move around from here. Nice to control the back of the knee. And you have the same options right here where I'm going to sink in and I'm going to give what's called a soft thumb. So I'm going to use this nice soft edge right there. I'm just going to scoop in like that. And then I'm going to change it and scoop into iliacus as well and follow the inside of the iliac fossa. So from here, you'll take a nice, find your ASIS, big breath in for me. And then as you breathe out, we're just going to follow our way down, working in. Actually, this is really good for you. Yeah, I can sink right in there. Excellent. And you can feel that little bit of, we hit the tissue barrier right there. And then from here, I can lengthen your leg, or I could drop your leg, or if I was really doing a good job, I could bring you all the way down like this, okay? And we can just kind of go repetitively through these, kind of a pin and stretch movement for psoas if you wanted to. If I wanted to get more into iliacus, I'm just going to change my angle a little bit. So now I'm going to come in around like this, and same kind of movement. If it's too much, let me know. You can't see much because of the way my hands are, but you can feel the pushing in, and just describe what it feels like as far as the pressure. It's minimal pressure, but it's minimal work for me, and we can work our way in there, and it's no pressure on my hands to actually reach way more specific tissue. Absolutely. And that's one thing I say for everybody. When somebody says they want deep tissue work, what do they actually mean? They want specific work is what they're looking for. So my apex of force, jiu-jitsu boys out there as well, so we can talk about this later. But when you're working, 2 hands against 1 is always going to be stronger. To follow up on what Terra did a little bit, which was fantastic, if you want to get into the adductors as well, because I guarantee that's going to be a thing, well, let's even do this. Bring both of your feet up, let your legs just drop out to the side. Most of us are probably going to be doing some kind of muscle energy technique from here where you can contract, relax, and work your way up. Or other options that I would have is, feel like you can kind of see it on the camera angles. I'm going to go right up to your adductor tubercle where the adductors attach, but my hands aren't going to go there. I'm just going to use this edge right here. Same thing. If anything's too much, let me know right away. Realistically, you want to make sure that you create good borders, so you can have a hand that reaches across like this to create a border, or if I was going to work on psoas, I'd actually go opposite side, and that leaves this whole side open for me to treat right here. Okay. All right. So from here, again, you could have the person draped, you could have them in a bathing suit, whatever's going to work for you. For a lot of our pro players, they know to wear bathing suits and different things that they can move to the side. But my strokes wind up going all the way down, following the adductors. I can reach right to the adductor tubercle. So you can see two hands against one. I grab the adductors right at their origination point, and we're going to pull and strip them back just a little bit. So from here, you can feel that edge right there. I can see you can get a little more tension. All I'm going to do is drop my body away just a little bit to give you a little more load, bring the muscles up a little bit more, grip, and move right there. And how does that feel for pressure? Yeah. But you can feel how specific we are and how deep we are. And I suspect you may not have had a treatment like this before, where someone reaches in and actually can grab that tissue that I physically couldn't reach with my hands in the same way. Yeah. Yeah. Nice. So you can see those movements right there. If I wanted to add even more to this, how much time do I have? I had a couple minutes. Okay. We're going to get crazy. All right. We're going to really get in. Well, maybe we'll get into this side psoas a little bit for you too. What I'm going to have you do, Ms. Garrett, I'm going to have you sit on the edge of this table right here. Like right on the very corner like this, so that your tailbone is right on the very corner. And then I need to exercise the demons. You have to fall back and bring a leg with you. Okay. All right. We have exercise the demons. Okay. Most of you are probably doing something like this, where you wind up moving the person around and stretching out. We can do better, all right? If I take my one hip and I lean up into your leg like that, that already creates preload. And look, Mom, no hands, okay? Last time I said that, I actually wiped out on my bike, and then it was not good. All right, childhood injury, there's no trauma, but there is, okay. All right, we're gonna load up just like that. From here, if you wanted to, you could still go just bare hands over top if you'd like, or I can find ASIS, get a little more medial. But everybody can appreciate how the psoas is in a lengthened position in this position right here. And you can also tell the way that her knee is kicking up, rectus femoris is probably pretty tight too, okay? So we're gonna turn this up a little bit. If it gets to be too much, let me know right away. What I'll usually do for most of our players is I'll hook in like this, and I'm gonna bring your foot in and crank up, and bring in and crank up. And how are you doing? Are you sure? That's a lot of movement right there. So most people give me a lot more tightness right off the bat. Oh, yeah. But you can feel the tightness through there. Yeah. All right. You have an option here. You could do a contract, relax if you wanted to. You can say, hey, can you push into me here, or can you push up to me there? So go ahead, either one. Yep. Easy, Hercules. Grab the table here. Okay. And keep going. 3, 2, 1, and relax. Nice. And then crank up and move through. Or I can go back with instruments the same way. This is going to be way more intense because the muscle's lifted up right here. But I can start to work through and work our way up psoas right there too if I wanted to. Yeah, doing okay? You sure? Yeah, nice. Okay, so some kind of movement like that. Now I've only done one side, so you're going to feel a little bit off balance with this. Can everybody gauge how relaxed my hands are? Okay, you could make enough pressure here in this position to actually have you, like, I'll crank it up a little bit. You tell me when to stop. Okay. Yeah, exactly. And that's probably about 30% of the pressure I could actually deliver. Okay, so it's way easier. So it feels like you as a therapist are doing nothing, but realistically, you're giving a higher dose where the person's like tap out kind of thing. Okay, so I'm giving that specific dose for you right there, and we'll get you up. All right, and even just take a couple of steps. What I really liked about Terra's thing that you did at the end too is you had her jump. That was fantastic. There's a bunch of research right now. If you actually want to prevent osteoporosis, which we all want to do for our patients, what do I need you to do? I need you to pound on the ground a little bit like that. So when you actually hit the ground, it actually creates more reactive forces in the body and creates better bone density, muscle mass and stuff too. Any questions for me? Okay. All right. Good stuff. We'll see you in the next visit.
Hi guys, I'm Caylea. Nice to meet you. Terra, nice to meet you. I'm not going to do too much. I don't want to irritate you. So I'm going to just add on to it. So I'm also going to look at how she's, maybe face the camera so they can see. Yeah. So I'd like to look at, see which side they're weight bearing more on. So if there's a favored side, so sometimes I like to still like work bilaterally. So I'm gonna actually do a standing forward bending test. You can't see in the camera, so just pretend. Can you lift up your shirt a little bit? And then you bend forward and reach for your toes for me. So you can't see it as much in the camera, but still when she's bending forward, she's more activated on the left side. So I would want to still make sure I want to see if it's ilium versus like sacrum. Can you sit with your back towards them? Because I want to do a seated forward bending test. This is a fancy table. Ideally, you would want to have both of their feet flat on the ground, but I don't think we can do that for today. So let's pretend she has her feet on the ground because that's going to give more pressure into the SI joints. And so even now when she's sitting heavier on her right side. So she's not putting a lot of weight through this left side. She's still avoiding this side. So I'm going to have you just bend forward like you're going to reach for the floor. And my top hands are on the top of the base of the sacrum. Come back up. And I want to look for it to move equally, and the left side's not. And I'm going to now go to the kind of inferior lateral angles of the sacrum and go ahead. So she still got this vertical SI thing going on this side, which could also, and you see your right hip, correct, Terra? So this could be compensating for the pattern that's going on this side. If you don't mind laying on your back for me. So even before I start treating, I like to look at all the different points because then it kind of gives me a map of where I'm going to go. Because I typically will start with a bit more soft tissue. So even here, when I'm looking at the angles of her feet, this right leg is, I'm going to call it apparently shorter. Doesn't mean it's actually shorter, but it's definitely, this is your problematic side anyway. So she's quite resistant. Even when she's doing rebound, like this side doesn't move very well. Can I check your pubic branch? Is that okay? The next part is after the other two did, those top points are all balanced. So what I like to do in this case too, depending on where her tension is, I like to do a lot more myofascial work to kind of loosen up that area. So I'm going to start with, I'm going to do like a lateral fascial chain stretch on this side. So can you just lean on this side a little bit? Yeah, because if you don't have them up on their hip, it could create too much of a torque on the lower back, and it might give you a bit of a back spasm when I go to put you back down. But when I do a lateral fascial stretch, because I want to dig up the entire length and right into the hip capsule, so I'll do a couple angles. I'll start with to the foot, because it's the entire chain. Sometimes I'll get I can't reach, I'm really short, so at the end I'll need to go like this, but I can't reach. They would be able to reach, but I can't. You can put your arm back down though. So when I'm doing this lateral, I kind of like to find the angle of what, like I don't want to put her here, that's going to put way too much torque on her lower back. So I'm going to just come back to whatever her more neutral. Is that painful at all? So for this is a couple multi-step when I do for this lateral fascial. So I like to start with the bottom. So my first is more of I distract and I kind of create a compression to put this on the tension, and I will actually even go right up into the hip. So if I go here, I'm gone too far, but I'm just trying to go to here. And can you feel that tension? And sometimes I'll even move the ankle to kind of get fibula involvement to get it out of the way. And as I move the chain, then I'm going to progress it. But I want to kind of stabilize because I don't want to pull you off your hip and create that into the lower back. So the same thing, I'm going to create an elongation and a bit of compression like towards the table, stabilizing this top pain because I don't want it to go into the lumbar spine. Is that okay? And then if it's an athlete or something, I might actually increase. I might kind of go up here, but that's too much for your joint. And there's not necessarily, there's no time frame of when and how long to hold this for. It's how long her body takes to wanting to release. So when I feel in my hands for a fascial release, I'll feel my two hands pulling back together. Can you feel the pulsing? My hands pulling back together. And I'll keep moving up that chain. I have your hand out. Is it okay if I put my hand on your lips? So this top hand again is more of a reference point, so make sure I don't pull too far or compress too far. And also I want to keep that. I don't want to go into the thoracic spine. I don't want to create that rotation. So again, I'm going to kind of compress down. I'm going to elongate. And then this hand, I like to hook it on the top of the fibula, just because it gives you kind of a good hook. Is that okay? That's good. I'm glad it feels great. And I would obviously, even if this is the problematic side, I would do it bilateral, because if not, it feels like you're walking in circles. Or you have a nice stretch side. And I'm going to pretend to reach, so I'm going to have you put your arm over your head. And ideally, if you have nice long arms, you can go to like wrist to ankle, but I can't reach, so we'll just pretend. But you can still create that elongation. Again, we're trying to minimize that lumbar rotation. Is that okay on your shoulder? Obviously, if they have shoulder problems, you don't want to put their arm in this. It'll be too much for them. And even, you probably can't see it, but even this end range, I'm also fine tuning. I kind of internally, externally rotate both bottom and top to find the most optimal. You can go into ease or you can go into direct. So ease is kind of provides the tissues the least amount of resistance, and if I go into the resistance, it kind of just builds it up. And take a breath in. And just bring that arm down. We'd like to protect that lower back. I'm gonna have you bend both knees. And I'm gonna have you lift your pelvis off the table. Kind of to bridge you up and back down. I just do that at the end just to kind of rebalance that pelvis, just like the jumping is when you get down on the floor. Kind of resets everything. So even just by doing that lateral fascial chain, now her ankles and her knee points are now level. Better check the top, make sure I didn't unbalance them. So even now this has more spring. And the other thing I would do, because I feel like when I'm rebounding this side, there's still resistance at that SI. So I like to do a bit of a sacral float, or cranial sacral, but it's sacral float. May I put my hand under your, bend this knee? And put this leg back down. Actually, can you put this leg back down straight? So in this position too, to engage the SI more, you actually can create a bridge between the SIs. You can kind of hook your forearm from one ASIS to the other ilium and create like a bridge. So when you squeeze them together, it bridges the ones in the back. It creates a gap. And it'll allow that sacrum to drop down and be able to rock better. And even in this, when I have the bridge, sometimes I'll even, and you can't see it, but I'll even create like an inferior traction with my sacral ham to kind of get it away from L5. I don't pull too much. Like if I pull here, you can feel that right into L5, and I don't want that. So I'm just gonna stay in the sacrum. And again, this technique, I find once the sacrum starts rocking, when it gets freed up from the ilium, So if in this case, your body's still struggling, like this right SI. So in my world, that's more, it could be more like visceral somatic. That's pulling from this area. If you've had any ovaries, colon, not that you need to say if you're constipated or not, but. And or pelvic floor. I know Terra is saying we were talking about scoliosis, so that right side of the pelvic floor could just be more involved. So we're getting movement now, so it's not as stuck. Another trick I like to use, I'll have them inhale and hold their breath as long as you possibly can, and when you can no longer hold it, just exhale. This helps kind of increase the energy in the areas that I'm working. Power of the breath, it helps a lot. Good, and take another deep breath in and out. So now I don't feel that I don't know if you don't feel, but I don't feel that resistance as much. So now even with your traction, you can kind of, it's a nice line all the way up where this side is. When I'm tractioning here, I'm still getting stuck right here. Can't get it past there. Do you mind, can you switch around so they can see? 1 minute. Okay, I'll just do the hand placement. So this is another myofascial technique that I'll do, where I'll have them bend their knee. It's like a 3.1. We'll have my bottom hand on the pelvic floor, my right hand on like the PSIS, and or I'll have the one on the top hand as well. So I'll do the top hand. So I'll do PSIS, and I grab this leg up. Yeah, I can go this way, and on this hand I kind of create a scoop. So it's like a 3-point traction into the iliac fossa. But I think for you, I like to play with traction versus if I need to lift it up and move it with your body. I feel like your body doesn't like, your body likes this area. So I'll pull it, her body likes more flexion, and I'm creating the traction. And hopes that will create the rebound. But I only have 1 minute left, so I can't finish this, but I'll just do some circumduction. All right, Terra. Good luck. You got one more to go.
I'm Troy. Nice to meet you, Kara. How you feeling? So I get to do the fun stuff. I get to do the wrap up, right? I get to do all the feel good stuff because they've taken care of you. So I have very little left to do except make you feel good, walk away happy. So any pain left? Any symptoms left? Still have some nerve pain. Okay. So because you have nerve pain, what I'm going to have you do, so they all did a wonderful job. They're all great. I'm going to move much more superficial. I'm going to move away from everything depth related. So I'm going to have you lay down with your head over here and your back to them. Just like that, yeah. Your nerve pain, how far down does it go? Usually down to the foot, but right now it's just superior to the knee. Okay, fantastic. And where does it originate? Do you feel it more at the hip? Do you feel it at the sacrum? Do you feel it right there in the glutes? So here to here. Okay, so I'm going to do just a brushing technique, just like this. I'm under 5 grams of pressure, only away from the brain, and I want you to tell me when that nerve sensation disappears. So she only feels it in the thigh now, so I'm going to switch to the thigh. So because it's nerve, this potentially is neuropathic pain, could be structurally based, could be memory based, could be habituation based. So because they've dealt with the structure, I don't have to. So I got to do all the feel good stuff. Now because it's her nerves, sensory system is kind of based on limitations, meaning it either feels really good and we don't care about it, or it feels really bad and we care a lot about it. How's it feel now? It's almost completely gone? Okay, we'll keep doing this a little bit longer. This is a technique that's wonderful too, because you can give it to them to do themselves. You can give it to a spouse to do. They just do it on their own. 3 to 10 grams of pressure, nothing else. And it's just because it's nerve pain. Nerves don't like being poked. They don't like being prodded. So I'm not going to go in with depth. And once it goes away, and her sensory system is the thing that will tell me it's done, because she will verbally tell me no more pain, no more symptom. When that happens, then I'm going to start going in with depth, but not until then. Completely gone? Okay, fantastic. So now, because she was saying it was from here to here, normally down the foot, do you also normally get it in the low back, the glutes, or does it just go down the leg? So sometimes the back, they're two separate. Okay. Because it starts here, I'm just going to go to the origin, and I'm going to have her, I'm going to go along piriformis, and I'm just going to have her tell me. And the reason I'm doing piriformis is not because of piriformis syndrome. I haven't asked her if she has that. I don't know if she has that, and I'm not going to think she has that. What I was doing when I did this, she said this was her area of pain. So I'm going to start in the boundaries and work towards the center. So you just let me know which of these is the most sensitive to touch. 1, 2, 3, 4, 5. 1 and 5. So which was the worst? 1, 5. 5. This is, I'm not even tracing along the piriformis. You know, this is the angle change. So I'm definitely not going on muscle base. I'm going on her sensory system. Her nervous system is telling me where her discomfort is. So I'm just going to pay attention to that. I'm going to apply pressure. I want you to stop me before a grimace. But I want you to let yourself get close to the grimace. Now, they don't see your face, so they're going to have to trust that I'm doing it. So you can do a thumbs up if you want. However, because you're on camera, don't make it look bigger. Don't be strong. Just as soon as your nervous system says it's enough, it's enough. And usually what happens when you ask people to tell me when it's a grimace is they usually go, I can take it. Well, that's a grimace, right? They're just not telling you. So let me know when that's enough. Right there. So I'm applying maybe about 400 grams of pressure. I'm not deep into her bone. If I do the same amount of pressure here, barely anything. Yeah. What I want you to do is this point here, I want you to let me know when the discomfort drops down to a mild or completely disappears. Take all the time you need. Gone? Mild? Maybe. Why don't we wait until you tell me it's 100% mild? Doesn't have to be disappeared, just tolerable. Mild. So now I'm not going to come out again because her nervous system, her sensory system has given me its limit. If I come back out, I might find the same limit. But now I was at her previous almost grimace. I'm just going to go deeper because her new grimace is going to be with more pressure. So again, before a grimace, stop. Body position wise, I'm not showing you good body mechanics. I'd be behind, I'd have an elbow, all that kind of stuff, but it's so you guys can see. So we're just going to hang on to it. And while we wait for them to tell us it feels better, it's a great opportunity to get to know your client. So, knock, knock. Cargo. Sorry, I couldn't hear you guys. Knock, knock. Cargo? No, cargo vroom vroom. Owl go who? You're welcome, Mark. So, why did I do that? I'm distracting her. Sure, it's a bad dad joke. But comedy releases oxytocin, endorphins, and dopamine. All natural painkillers. Is that still sensitive? Can I go deeper? I'm not going to come out again. I'm just going to go deeper. Almost a grimace. And when that gets better. Yeah. Why did the chicken cross the road? It sounds horrible, and my clients, they get sick of my jokes, but I'm not kidding. Comedy goes a long way to helping clients feel better. Not only about you. Oh, they're much after saying a joke like that, it's much less intimidating to be around me, right? Like it's just not intimidating anymore. So there's no more pain. So we slowly come out. 4 minutes, right? 2 minutes? Okay. Which is the most sensitive here? 1, 2, 3, 4, 5. 4. Well, that's almost a grimace. Okay. I'm not going to go through the whole set because we're going to be short on time, but normally I would do this. Tell me when it's pain-free. more bad jokes. She gets to tell me all her bad jokes. I build up a bigger repertoire. It's fantastic. On and on and on. We would work our way to the center, and then we'd wrap it up. So just let me know when that's tolerable. Yeah. So I'm done now. Any symptoms left? Any of that numbness come back to the leg? Okay, so instead of assuming that's the end all be all, I'm gonna have you stand up. I'll have you do the hop that Terra had you do. I'll have you do the squat. So I'll have you do a hop and a squat. And then a squat. There you go, come on up. Now I'm not checking her ranges of motion because I didn't start that way. I'm gonna ask her, is any of the pain still present? The ache is still present, less painful, and it feels different. Those are all positive changes. So this is light finishing work that lets you just walk away feeling happy, giggly. The other work is more structural, but it's one of the great things about the Masterminds that you get to experience all of that. Thanks so much for being our demo. Thank you, everybody.